Starting on immunomodulators, you have a near normal vision. Quickly, last
Can you
1
wrap
minute,
up?
I'll take a third case, very interesting, a 10-year-old male child. Again, a very vague history of some vision loss in either of the eyes, and you see the vision here with ocular findings nearly normal. Fundus nearly normal, no obvious disc edema, and the visual fields shows a centrocecal scotoma in the left eye, the right eye is more or less normal. VEP does not show an interocular variability, but there is a delayed latency in the 15-minute, in the 7-minute checkerboard size, but there is not much of interocular difference. So could it be optic neuritis, centrocecal scotoma? Maybe. You do an MRI, it's essentially normal, subtle T2 hyperintensity, but nothing on the post-contrast. Still not very sure, it's not consistent. You do autoimmune panel, everything comes out to be negative, with the fear that we don't have a further progression of vision loss and it could be still optic neuritis. You start patient on IV steroids, vision more or less remains the same. Little better than what he presented, but very vague. Now you do a pedigree analysis to look at this.
Can we wrap up?
Yeah, so this is my last 2 slides. Pedigree, proband is here, no other family history. We do a targeted sequencing of just mitochondrial genome and we find to be LHO and Leber's hereditary optic neuropathy. Very surprising with the common one of 11778 positive. Do we treat? Do we observe? We chose to observe. We don't know about many treatment options for children. Vision remains the same, but you look at the visual fields, slight improvement over the period of time. So neuroophthalmic causes for vision loss in children requires a very comprehensive evaluation. You have to be a slight pediatrician, neurologist, or take help from them. And role of neuroimaging is of paramount importance in this and should always be done in all children where you suspect a cause of neuroophthalmic issue. And diagnosis and intervention at early stage would really, really help them, specifically for CVI children, so it should be paid attention to. Thank you for your patience. Thank you so much.
Thank you, Janil. Thanks. So Janil was our opening batsman and he's in Mumbai at Shantilal Sanghvi Eye Institute. So I'd also welcome Dr. Rashmin Gandhi, who is our chairperson. Please come and sit on stage. So I think I'll just go next quickly with my talk, and then we'll have Dr. Rashmin, and then we'll have 2 speakers who are connecting from interstate on Zoom. Okay, so I'm just quickly going to go through the top 5 neuroophthalmic emergencies that we may encounter in our practice or in our institute. And these are really important, so I've written not to miss. So what's important in this is that some of these can be life-threatening or sight-threatening. It may even carry some medico-legal significance. Hence, a careful history and assessment is important because very often that is the crux to the diagnosis. So this is just going to be 5 short cases. So case 1 is a 47-year-old male who came from interstate, from one of the states in East India. And he had consulted locally previously, and he at that time complained that he's unable to see from the side. So he said, I can't see on either sides. And when he actually consulted with his ophthalmologist, he was prescribed glasses, and then he was said nothing else is wrong. And then after a few months, he presented with sudden bilateral loss of vision. And when he came to the emergency, that's when he had neuroimaging. And when later on he came to us, to Hyderabad, and this was his fundus appearance, where we can see some pallor temporarily in both the eyes. And what's more interesting in this neuroimaging is this large pituitary mass sitting here. And as you can see, there are some hyperdense areas as well. So he had bleeding into the pituitary adenoma, which presented with this sudden loss of vision. So this, depending upon the size, the degree of bleeding, is a life-threatening emergency. So any patient who does complain of some vision loss, other than just checking his his vision, also doing a visual field at that time would have definitely picked up a bitemporal hemianopia, and would have suggested further neuroimaging. In addition to performing optic nerve functions. So in this case, the visual fields should have really been done to pick it up early and avoid this scatterstroke. So now he's like a young 30-year-old with no light perception in both eyes. He has his entire lifetime. So I think this is a very important neuro-ophthalmic emergency that we should not miss. That is pituitary apoplexy. Now we come to a second case. This is a young male. He presented to the emergency with sudden onset of diplopia. He also had a droopy upper eyelid on the left side, as you can see over here. His pupil was mid-dilated on that side. There was an absent direct response, and the other cranial nerves were intact. So as you can see, the eye is exotropic. He had limitation of elevation, depression, and adduction of that eye. So what I'm trying to suggest is that, why is there so much echo? I don't know. But what I'm trying to suggest is that this is a case of incomplete third cranial nerve palsy and very likely compressive etiology because of the involvement of the pupil. So this is another very important neuro-ophthalmic emergency, because in this case, compressive lesions could also be aneurysm, like a posterior communicating artery aneurysm. And in this case, this patient did have the aneurysm, and these are at risk of rupture, and this can involve, again, this can be life-threatening to the patient. So this is one emergency where you would advise for an urgent MR angio or a CT angio. A CT angio definitely picks up even smaller size images. So this would be another emergency where even in the middle of the night you need to do neuroimaging, it's required. And this patient then had an urgent referral to neurosurgery. He underwent coiling of the aneurysm. So another important thing, young patient with incomplete third cranial nerve palsy, we need to think of compressive etiology and need an urgent MRI with an CT or MR angio. This is our third patient. So after coming to these two neuro-ophthalmic emergencies, the next couple of patients are the ones who are presenting with disc edema. And when they come with this kind of bilateral disc edema, it's very important to rule out whether there is any intracranial tumor or whether there is any malignant hypertension or idiopathic intracranial hypertension. So I'm just going to go through quickly 2 slides. So this is a young female with sudden onset blurry vision, and this vision rapidly deteriorated over the next 2 to 3 days. She had no history of fevers or rashes or any medications that she was on. And this was the appearance of a disc. It's a florid disc edema, as you can see in these pictures over here. Also, she had her visual fields which were grossly affected. The OCT here shows both RNFL as well as the neuroretinal rim elevation. So the disc edema is definitely profound. And the fact that she's losing vision so rapidly, we went ahead with an MRI with MR angio, with MRV. And here we can see that she has an empty cella. She has flattening of the globes. Basically, she has features suggestive of idiopathic intracranial hypertension with narrowing of the transverse sinuses as well. So just with regards to the urgency of the case, she underwent optic nerve sheath fenestration, where a small window is made into the optic nerve sheath to release the fluid that is causing this compression and rapid vision loss. And after the procedure, a few weeks later, her disc edema had resolved, and she did manage to retain and gain some of the lost vision. So this is another important neuro-ophthalmic emergency, and where rapid loss of vision can sometimes be irreversible if not intervened in a timely fashion. So again, next, as I mentioned, is malignant hypertension. So any case of disc edema that you see a simple blood pressure is very important in these cases because it will just avoid all unnecessary tests of doing MRI and MRV and whatever else that we are suspecting. So that's one of the first things that we should do in any patient that presents either to our clinic or emergency. Just take their blood pressure. And if it is soaring high, then we know that given these disc findings or these areas of cotton wool spots and retinal ischemia, we're probably dealing with a malignant hypertension. This is my last case. So this is a 90-day ischemic optic neuropathy, which I would like to draw everyone's attention to. So giant cell arteritis is something we don't see as often in our country, but this is something which I used to see right, left, and center when I was working in Australia. So any case, any elderly patient above the age of 50 years who would present with sudden loss of vision in one eye, we have to rule out arthritic AION unless proven otherwise. Often they will have complaints of headaches or jaw claudication or tender temples. Sometimes they may not even have those. They may be in the setting of rheumatoid arthritis or rheumatism, and they would present with a raised ESR that is raised above their expected age value, raised CRP and platelets. So this this 64-year-old patient, he came with sudden onset loss of vision in the left eye. His vision was recorded as about 2800. The image is not so great, but we can see the disc edema on that left side. His ESR was a soaring 101, and his CRP was 42. He also did have headaches, but he did not say he had any jaw claudication. In fact, that's one test which you ask the patient to actually chew, and there's been a lot of literature on that. You can even give him a chewing gum and ask him to chew and see if he's got pain when he's doing that particular action. So, with this setting, a giant cell arteritis or an AION was expected, and in this it's important to try and preserve and protect the remaining vision in the other eye. So this is a few days later when he had pallid disc edema, but he was taken up for a biopsy where we performed a temporal artery biopsy. Try and see if I can play this. So I've just shown a small clip of this where the superficial temporal artery is identified. It is just below the skin. When we palpate it, you can mark it and take a little biopsy segment of that. So this is where we are actually marking the skin, exposing the artery, dissecting around it, dissecting a segment of at least about 1 centimeter, 1 to 2 is ideal, and then fishing out that segment and sending it for histopathology. And these patients need to be managed with months and months of oral steroids, starting with very high doses and monitoring their serial ESR and CRP values. So I'm just going to end with a conclusion slide that these were the top 5 emergencies, but there are a lot more in neuro-ophthalmology. So these emergencies can be both life and sight-threatening. And timely investigations and appropriate management is crucial. Very often we need to involve multiple disciplines like neuroradiology, neurology, and neurosurgery. And because we have so much of collaboration and interaction with these disciplines, I would end my talk by sharing this slide where we have an imaging and neuro-ophthalmology conference and workshop, which is on the end of August. And I'd invite all of you to participate in that. Thank you so much. And now we'll move on to Dr. Rashmin Gandhi. After Rashmin's talk, we'll take questions for Dr. Rashmin Gandhi as he has to go to another session, but for the rest of the speakers, we'll be happy to answer at the end.
Thank you. Thank you, Dr. Manju. And thank you for your kind invite to make me part of this very nice instruction course. So my job is to talk about what's new, mainly in optic neuritis, though I'll touch upon a few other points where there is some development in neuro-ophthalmology. These are 3 main areas where there's a lot of work which is being done. One is, of course, in the area of optic neuritis, which is one of the commonest optic neuropathies. A lot of diagnostic tools being worked upon to make sure that we have accurate or early diagnosis of these neuro-ophthalmic problems. And there is a lot of exciting work going on in genetic engineering where LHON, Leber's hereditary optic neuropathy, is one of the first diseases in the body where genetic engineering has shown a good promise. But let's talk about optic neuritis. there is a lot of change in the way we understand this inflammation of the optic nerve. Last century, or maybe 2 centuries ago, and this is from a famous, at that time, a famous neuroscientist, neurologist, or philosopher from Britain, Walter Bailey. So he used to think that optic nerve is like a tube which connects the eyeball to the brain, and the eyeball would communicate with the brain because of the passing of the spirit. And if that spirit is not working well, is where you develop the problem of blindness because of optic nerve. And he thought about this problem, saying, how can we deal with this bad spirit? And the treatment that he recommended was to comb the hair 3 times a day for 1 week. And he thought that if you keep combing your hair, the spirit from the scalp will be drawn from the optic nerve through the scalp, will go out, and patient will recover the vision. Of course, that's not Walter Bailey, that's my photograph. But of course, he didn't think of a group of people who may not benefit by that treatment. From there to a lot of, as I said, a lot of developments. And I'm going to answer these 3 questions. What were the older concepts and how they have changed? And why it is relevant for us as an ophthalmologist. And a lot of times when you see a patient with optic neuritis, first thing we do is, okay, send them to neurologist, and then most of the time we lose track of these patients. However, now with this, all these new developments in optic neuritis, we actually have become a centerpiece, and if not centerpiece, a very important part of the team which would manage this optic neuritis. And I'll prove it with some of the data. What used to be believed are all our current or older knowledge of optic neuritis came from a trial called ONTT, which was conducted in the US. So it said that optic neuritis essentially is a self-limiting problem in more than 90% of the people. If you have an access to MRI, you do it, otherwise it's all right. If you can give steroids, it's great. If you can't give steroids, at the end of 6 weeks, patient would recover normal vision. And it also said that optic neuritis is essentially a problem of young female, more in Caucasian. So these were main important parameters which ONTT taught us. However, now it has changed. As I said, it used to be believed that it's a disease of a young adult female. Maybe you can add a caveat saying more common in whites or Caucasians. However, now we have optic neuritis, which is thought to be mediated by circulating antibodies, and there are 2 of them which are known right now. And there we know that optic neuritis can essentially occur at any age. It can also occur in a younger age, older age, females, males, almost equal preponderance. Caucasians, as I said, it used to be believed more common in Caucasians than blacks and Asians. What about acuity and disc? It was believed that the typical, what used to be called as typical optic neuritis, will generally produce mild to moderate vision loss, would have very few of them, and as we all probably, a lot of us would have read in the textbook saying, optic neuritis essentially is retrobulbar neuritis. You will find most of these patients have no disc edema. And it would be unilateral. It can be sequential, but it will be unilateral. But now with the new knowledge, that a lot of the optic neuritis which are mediated because of antibodies have severe vision loss at presentation. They can have a bilateral presentation. A lot of these patients now we see have a disc edema. So there is a possibility that in the olden era, before this knowledge was available to us, a lot of these patients would have been diagnosed as having AION because we thought that optic neuritis would not produce disc edema so readily. So what about the prognosis and recovery? It was believed, according to ONTT, that all the patients who develop, or more than 90% of the patients who develop optic neuritis would have an excellent recovery. And even if you don't give steroids, at the end of 6 weeks, they would come back to pre-attack visual recovery. However, the optic neuritis that now is considered because of which patient get because of circulating antibodies, they seem to have at least one of the antibodies which attack the optic nerve. It seemed to have a fairly poor visual recovery. So when do I suspect? When do I say that, oh, I'm dealing with this optic neuritis which seemed to be because of circulating antibodies? Absence of pain. According to ONTT, again I go back to ONTT because that was what our up-to-date knowledge was till 10 years ago, said that almost everybody who has optic neuritis would complain of pain which get aggravated by eye movement. However, if you have a patient who does not complain of any significant pain and you suspect optic neuritis, you know that maybe you are dealing with optic neuritis which is because of circulating antibodies. Disc edema and bilateral presentation, severe vision loss on presentation, minimal to no visual recovery 2 weeks after administering steroids is where you start thinking of optic neuritis, which is mediated because of circulating antibodies, recurrence and other neurological deficits. What else would you ask for? So every patient who comes now with optic neuritis, some of these questions or findings you should be looking for. One of the important findings, a lot of these, weakness, painful spasms, they all might end up with neurologist. But patient who has a vision loss and who come to us may have vomiting or hiccups. Hiccups is an important symptom that we should ask for almost all the patients who come with optic neuritis. And I'll tell you why we should be asking for hiccups. It's because this subgroup of optic neuritis called NMO, and what Janine also mentioned about, neuromyelitis optica. What is neuromyelitis optica? Neuromyelitis optica is a form of optic neuritis where there are antibodies against aquaporin 4, and because of these antibodies, there is an immune reaction and optic nerve gets inflamed, so that it behaves differently from what is known as typical optic neuritis. And apart from those symptoms, bilateral presentation, disc edema, symptom of hiccups, how else can we diagnose? And that's where another important difference. We used to say that if patient does not afford MRI, it's all right not to do MRI in patients with typical optic neuritis. Now, it is important to request for MRI, brain and orbit with contrast in everybody in whom we are suspecting optic neuritis. The reason is some of the clues of atypical or antibody-mediated optic neuritis will come from MRI. MRI, if it involves optic tract, that's not a feature of what is known as typical optic neuritis. And it also can involve areas in hypothalamus like area postrema or nucleus tractus solitarius. Area postrema involvement is what leads to repeated hiccups, and that's the reason why you should be asking for hiccups in patients who have optic neuritis. So how does the treatment differ? Of course, all these patients with optic neuritis would be given IV methylprednisolone. Generally, it is 1 gram per day. It can be 30 milligram per kilogram in pediatric age group. But a lot of these patients are at a high risk of developing paraplegia or other neurological deficit. And so if you find somebody who has acute vision loss, profound vision loss, has disc edema on presentation, they may be the right candidate to undergo plasma exchange, which will be done by neurologists, but that's something which we would be suggesting, that patient has a profound vision loss, patient has a bilateral presentation, or patient has disc edema. So all this neurologists will not know. We would be telling them, saying these are the findings, and that's the reason I'm suspecting that patient might be having antibodies, and so the treatment might be different. The other treatment, again, which is in the realm of neurology, would be azathioprine, Plex, or IVIG. So one antibody is this NMO, aquaporin 4, and the disease is called NMO or Devick's disease. The other antibody which is known to us right now is MOG, which is also which has a very similar spectrum as NMO, but this has more common association with other issues like encephalitis. It has a better recovery, and again, MRI would be an excellent guide towards us to say that, yeah, we may be dealing with optic neuritis, which is because of circulating MOG antibodies. So in NMO, I said that you will have an involvement with optic tract. In MOG antibody-mediated optic neuritis, you will find perineuritis, what Dr. Sheth mentioned as that there'll be widening, there'll be perineural involvement, so there'll be horizontal involvement of the optic nerve in patients who have optic neuritis because of MOG. So why it relevant for us, as I said, we need to tell the neurologist that disc edema, bilateral presentation, acute loss of vision. Some of these patients may require a long-term immunosuppression or even plasma exchange. A word about OCT and then I'll end my talk. OCT has gained a lot of momentum in disorders of optic nerve. It is believed that maybe just by doing OCT, we can differentiate between a pseudo disc edema and a disc edema, though it is still not mature enough for us to say that that would be the only test or a gold standard. OCT can be used for prognostication. Somebody who has, let's say, pituitary adenoma and is going to undergo neurosurgery, if you do pre-operative OCT, and if you find that average RNFL is above 80, you know that prognosis of recovery of visual field or vision following neurosurgery is likely to be much better. If the average RNFL is lesser than 60, you know that there is a possibility that this patient may not have a good visual recovery. And a follow-up of patient who has raised ICP, if you do OCT at each visit, you would know whether patient is recovering, whether disc edema is going down, you have an objective assessment of it. So to conclude, I want to say that because of this new knowledge in optic neuritis, that optic neuritis can be mediated because of antibody, our role has become very important in diagnosis and follow-up of these patients. I thank you once again.
Thank you so much, Rashmi. That was an excellent talk. And if anyone has questions, please catch him outside the door because we actually have to have 2 more speakers and we should give the session on time. So I'd like to invite Dr. Jyoti Matalia, who's going to be connecting on Zoom. And she will be speaking on ocular myasthenia gravis. So Jyoti is going to be connecting from Bangalore. And please quickly catch Rashmin before he goes to another hall and ask him whatever questions you may have. We can't hear.
Yeah, thanks, Dr. Manju.
Yes,
for
we
the
can hear you.
invitation also and for your kind introduction. Just 1 minute, I'm making my presentation. Yes, so can you see my slides?
Yes, yes. Please go ahead.
Yeah, right. So I'm going to be talking on ocular myasthenia gravis, diagnosis and management. And I'll be taking you through the basics of myasthenia gravis, the pathophysiology, the diagnostic tests, and the management options. So as we all know that ocular myasthenia gravis, which I'm going to call as OMG, is a disease of the neuromuscular junction. And primarily for ophthalmologists, it's important because it affects the ocularis oculi muscles, as you can see, and the extraocular muscles in both eyes. And therefore, that's how the patient presents to us. So let's understand what is the pathophysiology behind that. As I said, it's a chronic autoimmune neuromuscular disease that causes the weakness in the skeletal muscles. So now you know that acetylcholine, as it's released from the neuromuscular junction, it binds to the acetylcholine receptors which are there and an end potential is generated. And that's how a muscle contraction occurs. But in OMG, there is, or in myasthenia gravis, there is acetylcholine receptor antibodies which destroy these receptors, due to which acetylcholine does not bind to anything and there is no muscle contraction and fatigability comes. The other important proteins that we should be aware of is muscle-specific kinase and LRP4, which are important in clustering these receptors which are affected in OMG. So OMG is what I'm going to be primarily talking of because it's ocular disease. Now let's go on to deciding how do you detect a patient with ocular myasthenia gravis. Primarily clinical features. A patient will present with ptosis, either bilateral or unilateral. If unilateral, there may be a lid retraction of the other eye. Like you can see in this case, the right eye has a ptosis and left eye looks lid retracted. And the classical sign is eyelid curtaining, which means lifting of the ptoted eye may result in the ptosis of the other eyelid, as you can see here. And this is very classically what you should test in your OPD. Then the other aspect is diplopia. Patient will present with ophthalmoparesis and an unexplained ocular motility. So when you see a patient where the motility does not fit into a particular spectrum, no specific cranial nerve paresis or something which is unusual, always think of myasthenia gravis. And more importantly, the pupils are absolutely normal. Now let's classically look at how they would present. This is a fatigue test. Make them look upwards, and on sustained upgaze, you will see that the ptosis starts worsening, as in this case. And the classical Cogan's lid twitch sign, where if you make the patient look from down gaze to up gaze, you will see the classical twitch sign which is present. Now, as I said about ocular motility, right eye is perfectly normal, but look at the left eye, there's -2 adduction, -2 elevation. It doesn't fit into anything. Also remember, myasthenia can affect any age group, clinically isolated to either extraocular muscles, LPS, and orbicularis oculi muscle. It mimics isolated cranial nerve palsies, gaze palsies, INO, blepharospasm, so something which doesn't fit into any spectrum, think about it. The classical peak side of OMG is on sustained eyelid closure. Like in this patient, patient is unable to maintain the closure and the eye slightly opens up. Appears like a peekaboo sign. And this is the sign of orbicularis fatigue, which you should keep in mind. So to summarize, OMG is a clinical diagnosis provided the history and examinations are classic. But for subclinical cases, pharmacological and serological tests, electrophysiology, CT scan, etc. are required to unmask the latent signs. So let's go back to understanding what are the various things. This is pharmacological and clinical tests. So one is eyes test, simple and effective. You can do it in your clinic. All you need to do is you have to put the eyes on the eyelid, and classically works best for a patient who has ptosis. So here you can see for putting eyes on the eye for 2 minutes, you will see an immediate improvement. Remember to ensure that the eyes is actually touching your lid so that the effect is seen. The other is sleep test, 30 minutes, resolution of ptosis or ocular motility. So best is ask the patient or the parent if it's a child that when he gets up in the morning, are the eyes perfectly normal? And in fact, this is how we got a history from a child who had OMG. And then classically the hydrophonium test, but tensilon is no longer available. So the long-acting one, that is neostigmine test, can be used. And after 30 minutes, you'll see an improvement in ptosis. Remember, the sensitivity of the test is 95% for generalized cases, that is GMG, and about 86% for ocular cases. Then coming to serology, these are the various antibodies you look for. The anti-acetylcholine receptor antibodies. Remember, it's specific for generalized cases compared to ocular. But remember that normal titers does not exclude the disease. Then you have the anti-MuSK antibodies and the anti-LRP4 antibodies. But remember that in 10% of ocular cases, they can be triple negative. That is, all the 3 antibodies may be missing. Then the electrophysiological, you look for the single fiber electromyography, which is very, very specific, sensitive, and also a sensitive test of about 85 to 100% for ocular cases, as you can see here. And then the repetitive nerve stimulation study, which is decremental response in about 33% of pure cases. And finally, the others, more importantly, the CT scan to detect thymic hyperplasia and thymoma, and thyroid function tests to rule out any concurrent autoimmune thyroid disease. So now let's go back to the treatment. What are the options? Now the basic principle is 2 ways. Either increase acetylcholine receptor and availability, or preventing the binding of acetylcholine by preventing the binding of the receptors to the antibodies. So let's look at the 2 options, pharmacological or surgical. In pharmacological, we are looking at these 3, starting with importantly the pyridostigmine, in which it's a prototype drug, and it does not affect the natural history, but only 20 to 40% of ocular cases exhibit a favorable response. The other one is corticosteroid, which is a second line of treatment, is given along with pyridostigmine, and about 80% of cases with ocular myasthenia gravis exhibit significant clinical improvement. Now, this is a classical study which was done, the EPITOME study. It is randomized, double-masked, placebo-controlled, where they tested the safety, tolerability, and effectiveness of prednisolone, started a low dose, and titrated by increasing 5 milligram every 5 days till symptoms resolved. And they found that those on steroids did very well compared, that means 5 out of 6 compared to the placebos, there is no response at all. And the best dose that they found was 15 milligram per day, which is lower in cases of ocular than in the generalized cases. Immunotherapeutic agents, on the other hand, reserved for patients when corticosteroid risks exceed the benefits. They reduce the risk of the conversion of ocular cases to generalized and changes the natural course of the disease. There's a study in which 12% of ocular cases on immunosuppressants developed GMG against 64 who were not on immunosuppressants, indicating that this is definitely a better option. What are the various immunotherapeutic agents? Primarily the azathioprine, which works best for both ocular as well as generalized cases. Then mycophenolate mofetil, which is more effective in ocular cases. The IVIG and plasmapheresis, good in generalized cases. And rituximab for generalized cases of myasthenia gravis. Then coming to the surgical options, this is thymectomy, which is beneficial in patients during the early course of their disease with significant follicular hyperplasia of the thymus gland. But in non-thymomatous cases, that is ocular cases, complete stable remission has been achieved in 50% of the cases following thymectomy and improved symptoms in 20%. It can concern cases receptor antibody seropositive cases who become unresponsive to medical therapy. So finally, a short algorithm of these cases, because it's not very clear cut. So do a clinical examination, eyes test, sleep test, fatigue test, rule out signs of generalized, rule out alternative neurological pathology. And if you clinically suspect ocular cases, then you do antibody testing, the 3 antibodies that I mentioned. If that is seronegative, then you look electrodiagnostics, that is RNS, and the single fiber EMG. If that is, if consistent or if seropositive, you know it's a diagnosis of OMG and it gets confirmed. But if negative, then you have to do an MRI, again rule out other causes, consider empirical therapeutic trial, repeat antibody testing in about 6 to 12 months to again see if it develops, because that can eventually confirm OMG. So in summary, remember that myasthenia is a clinical diagnosis. It's a great mimicker. So anything in neuro-ophthalmology which does not fit without loss of vision and with normal pupils, think of myasthenia gravis. Also, Satak, OMG, if you're looking at any ptosis or diplopia, give importance to the history of variability and fatigability. Don't get biased by diagnosis done elsewhere, and coordinate with the neurologist to rule out any generalized cases of myasthenia gravis. Thank you very much.
Thank you very much, Jyoti. That was a great talk. With this, we'll move on to our last speaker, Dr. Virender Sachdeva, who will be speaking on approach to optic atrophy. And these are the cases which we see very commonly in the neuro-ophthalmic clinic with optic atrophy, and then we don't know how to go about. So Virender will help us, take us through this. Please reserve all your questions after Virender's talk for all speakers. We'll quickly go through a question-answer session. Thank you. Over to you, Viru.
Thank you, Dr. Manju. I hope I am audible.
Yes, you're audible.
Okay, thank you. So as you rightly said that we all come across a variety of patients who come with referral for a pallor or optic atrophy, and we see that they can be in different shades. Some of them showing up as a small area of temporal pallor, some like disc edema going into pallor, some showing significant attenuation of arterioles, and some with associated retinal changes. This tells the spectrum of changes that we see when we see a patient with optic atrophy. So we'll try to elucidate that, and in the interest of time, I will straight away try to take the cases. But just a small mention, for the benefit of PGs, we all know that there is a specific terminology or a classification that is described like primary, secondary, consecutive, glaucomatous, and cavernous. It's well described in your textbooks. But at the same time, it does not tell us the etiology of the condition always. Like a patient with RBN could develop a primary optic atrophy. A retrobulbar neuritis can go on to develop a primary optic atrophy, whereas a person with same optic neuritis with disc swelling can go on to develop a secondary optic atrophy. So what we propose and try to follow is that we subclassify optic atrophy into post-traumatic and non-traumatic, and the non-traumatic ones can be subclassified after a detailed workup into a status post-ischemic optic neuropathy, post-neuritic, glaucomatous, compressive, and consecutive subtypes. So let's begin with the first case. This is a 24-year-old lady who was referred to us for evaluation of optic atrophy. We see that the best-corrected visual acuity of patient was 20/60 in both eyes. There was no RAPD. Color vision was subnormal in both eyes. Now coming to the optic disc, we see that the rest of the fundus was unremarkable, though we can see only the disc in the photograph. You just take the word, my word for now. But if you look at the optic disc characteristics, we can see definite temporal pallor. The rest of the bulbs are not. And as I said before, rest retina is normal. So we went ahead and asked more about the history. The patient gave history of sudden onset vision loss a few years ago. This was preceded by an episode of fever. MRI at that time was normal. She was given treatment with some tablets. Only one tablet was given for a period of about 2-3 weeks. And the patient had substantial improvement, though not completely. So given this, with this picture, you can think that this could be a post-fever or a post-infectious optic neuritis that can present to us now with the partial optic atrophy. So we went ahead and did the visual fields. We see that there is a central scotoma on the pattern deviation plot in both eyes. And we did the VEP, which shows that the waveforms are quite preserved even up till the small size stimuli. The smallest size stimulus is the 7 minutes of arc or 7 minutes checkerboard size stimulus, and we can see that waveforms are preserved in the right eye and in the left eye until the 15 minutes checkerboard size. But what we see is that the time taken to reach the peak of P100 wave, the P100 implicit time is quite prolonged. It is around 131 and 135. So this picture is actually classical of a demyelinating optic neuritis. So possibly, given all the spectrum of findings now, we can assume that most likely this patient could be a status post optic neuritis going into partial optic atrophy. However, a person with temporal pallor and central centrocecal scotoma can have many other differential diagnoses. So history comes and plays a major role in these patients. Let's see these examples one by one. A young person presenting to us with subnormal vision, temporal pallor, central scotoma, giving a history that there is a sequential involvement, right eye followed by the left eye, could could be a labor hereditary optic neuropathy that was referred to before, especially if the patient is a male. A person being on ATT for 2 months presenting to us with acute onset, sudden vision loss, with moderate to profound vision impairment could be a toxic optic neuropathy. A gradual onset vision loss, usually with mild to moderate vision loss, in a patient who is strict vegetarian or who has GI disturbances, malabsorption syndromes, could be a nutritional optic neuropathy. And similarly, a very similar picture with mild to moderate vision loss with gradual onset and with family history of optic nerve issues or poor vision secondary to optic nerve problems could be an hereditary optic neuropathy, especially in patients where there is a family history of consanguinity and the patient gives history of diabetes and hearing loss. Do consider hereditary optic neuropathy, especially the autosomal recessive variety in these kind of situations. So to summarize, we saw a patient with temporal pallor and central centrocecal scotoma. Keep these 5 important differential diagnoses in your mind: post-neuritic optic atrophy, toxic optic neuropathy, hereditary optic neuropathy, LHON, and nutritional optic neuropathy. Now coming to the second pattern, a temporal along with temporal hemianopia or a junctional scotoma should raise patient could be having a lesion. In these patients, a tumor in the region of the pituitary area, which could be a craniopharyngioma or pituitary microadenoma, causing a compression and a compressive optic neuropathy. Let's move to another example. This is an example of a 10-year-old girl who was initially found to have a poor vision in left eye. She noticed it accidentally after closing the right eye. In the examination, patient's visual acuity was 20/20 right eye and only light perception in left eye. And anterior segment was unremarkable except for RAPD grade 4 in the left eye. What you see in the fundus picture, as compared to the previous presentations, here not only the optic disc is quite pale, but there is a diffuse attenuation of arterioles. There is diffuse RP changes, the RP mottling seen on the posterior pole extending up to the mid-periphery. So this is a patient who had a old vascular occlusion, most likely an ophthalmic artery occlusion. And these patients do not require a neuroimaging. Rather, they need to be looked up for the cardiovascular abnormalities, risk factors such as hypertension, diabetes, dyslipidemia, hyperhomocystinemia, and a 2D echo of the heart should be carried out to find out a possible prothrombotic risk factor or a source of embolus. This could also occur following a central retinal artery occlusion or a segmental picture like with segmental pallor along with segmental attenuation of arterioles could occur secondary to NAION. Let's move to the fourth pattern, which is like that of a post-papilledema optic atrophy. We can see that the disc is looking pale. There's a diffuse pallor. Along with that, you can see that there is a little attenuation of arterioles and there is a presence of RPE change mainly in the posterior pole area. This picture is usually seen when there has been a papilledema for a long time and raised ICP. So in these patients, we need to rule out intracranial infections, obstructive heterocephalus, fulminant IH, Arnold-Chiari malformation, and posterior fossa tumors. Again, neuroimaging is mandatory in these kind of patients. The last pattern that I would like to stress upon is that of a patient who presents to us with pallor, but there are multiple retinal changes like choroidal atrophy. There could be a beaten metal appearance on the posterior pole. So these kind of patients could be having a consecutive optic atrophy, and a thorough retinal evaluation and electrodiagnostics help us establish the diagnosis. Neuroimaging is not needed in these kind of patients. So we should look also for some of the systemic features like failure to thrive, nystagmus, systemic manifestations as lysosomal storage disorders, mucolipidosis can also present with a similar kind of picture. We should always rule out optic atrophy mimics like optic disc hypoplasia, coloboma, peripapillary atrophy in high myopia, and magnification of the disc, like taking a focus photograph of the optic disc can help us elucidate whether the person could be having a optic disc hypoplasia rather than just a temporal pallor. This would be important because this can have wide-ranging implications in the management of the patients. They can have hypopituitarism and growth retardation. So in conclusion, optic atrophy is merely a sign and not a final diagnosis. When we see a patient with optic atrophy, we try to rule out whether it's a mimic or a congenital optic disc anomaly. If it is so, we reassure the patient or work up accordingly. Otherwise, by history, we try to find out any predisposing risk factors like history of hypertension, diabetes, dyslipidemia, any precipitating events like acute rise in BP, any trauma, a pattern of the vision loss, like whether it was acute, such as in post-neuritic optic atrophy or ischemic optic neuropathy, or insidious, like in a compressive optic atrophy. Then we go back and look at what the patterns. We try to put the optic atrophy into one of the 5 patterns and then tailor-made the investigations. Visual fields, as I said before, plays a major role looking for the specific patterns like central centrocecal scotoma, altitudinal field effects, bitemporal hemianopias, which give us definite clues. And at times, the OCT of the MGCL can also help us give some clues, like we can see a binasal MGCL IPL thinning in a patient with bitemporal hemianopia and a segmental pallor in NAI1. So keep this picture in mind, put up the optic atrophy into one of the 5 major patterns, look at the associated visual fields and subclassify the disease that could be causing it. Thank you very much for a very patient hearing. And I would like to thank TOS and Dr. Manju for giving the invitation. And once again, I will extend the invitation to join our meeting on imaging and neuro-ophthalmology on August 26-27 at LV Prasad Institute, Hyderabad. Also, would like to invite you all for our innovation stall, which is there at the venue. Thank you.
Thank you very much, Virender. If there's any 1 or 2 burning questions, I'm just going to pass on the mic to Dr. Raman for the concluding remarks.
Hello, Dr. Virender. It's a nice
Yes.
talk. I want to ask you one question. Whenever
Yes, sir.
there is a unilateral optic atrophy, any indications for neuroimaging and what clinical scenario, especially
So,
unilateral optic atrophy?
Yes, sir. So I think, sir, as we discussed before, unilateral optic atrophy could occur secondary to a large variety of conditions. We would again go back and think whether the person could be having a orbital lesion. So because the optic nerve from the behind the globe till the chiasm, that entire area could be actually be having a unilateral optic atrophy. We should look out for those cases, and they can have any pattern of optic nerve kind of field effect. So if your suspicion is high, maybe we need to look for those.
Thank you so much.
Thank you everyone, all the speakers for participating in our session. I'd like to conclude and pass on to the next lot of speakers. Thank you.
Thank you.
Thank you.
Ophthalmic Society, particularly Dr. Rishi Swarup for giving me this opportunity to lead pediatric cataract capsule. So we have, Chairperson Vidyavati and moderator Dr. Raman. And today's thing is an advanced course in a pediatric cataract surgery in a special scenario. So this is the program in detail. We start up with Dr. Ramesha's thing where he would give us more detail about preoperative evaluation, critical period assessment, density of amblyopia, and timing of surgery, followed by Dr. Murali Krishnamachari. He'll be talking on the nuances in a pediatric cataract surgery. Myself, Muralidhar Ramappa, I'll be talking on a pediatric cataract surgery in anterior segment disorder. And we have our young retina colleague, Dr. Akash. He shall be covering on a persistent fetal vasculature from the posterior segment view, and decision making and management by one of our senior colleagues, Dr. Somashila, shall be talking on a uveitis in children. And finally, we have world-renowned glaucoma specialist, Dr. Mandal, shall be talking on a secondary glaucoma in a pediatric cataract surgery. Dr. Ramesha has indicated he is busy with other sessions, so I'll get started with my talk, followed by Dr. Murali Krishnamachari, and Dr. Ramesha will be delivering his talk on the end. If you look in terms of a pediatric, the visual development and a critical period of surgical intervention, so surgical challenges and various modifications which are necessary to maximize the functional outcome, and we also highlight surgical pearls to efficiently deal with the difficult and interesting cases. We would also share some of the interesting surgical scenario, and most important and the key is prompt visual rehabilitation in the children. It is much more than actually doing the surgery. We all know pediatric cataract surgery is a different ball game. It is not just we are dealing with a miniature eye of that of an adult. So wherein, in terms of a decision-making, timing, surgical technique, and very stringent post-operative follow-up is quite different that of an adult in order to ensure a good functional outcome. One of the major challenge in a pediatric cataract surgery is to not only to provide clear visual access, it has to be, complete spectacle correction and a prompt amblyopia therapy during a neuroplasticity to maximize the functional outcome. It also difficult sometimes, you may not get a complete history, and a thorough preoperative evaluation may be difficult, requiring a detailed history like an answer, duration, type of opacity that in turn, indicate the depth of amblyopia, presence of intra and intranetal problem that may even contribute to the cataract, and also overall development of a child does directly impact the functional outcome. This get compounded particularly when you have an anterior segment dysgenesis, which I am dealing with, and you have it in subluxation, coloboma, or lenticonus, that also, intraoperatively poses different challenges. Akash will be covering a spectrum of fetal vasculature from the posterior segment perspective, and he would, give us, certain examples. And there are modifications needed in each of these scenarios. And when you look at, pediatric cataract, sometimes associated with a diverse abnormality, it could be an anterior or a posterior segment, it could be having a glaucoma due to iris or a trabecular meshwork abnormality. They can pose a variety of clinical presentation and a diagnostic challenge. And very rarely, you can also have a tumors presenting as a cataract. So this has to be, although it is extremely rare, it's very important to recognize. Unlike adult, pediatric cataract surgery, at the time of surgery, each of these child have, 70 to, let's say, 90 years on average. So in a lifetime, sometime, you get to see variety of post-operative complications, which you normally do not see following an adult surgery. When you have an anterior segment abnormality, can have a visibility is a challenge. You have a crowded anterior chamber to deal with, may have an associated iris pupillary abnormality that again compounds your surgical maneuverability and also placing intraocular lens and so on. And since, when you have anterior segment developmental abnormality, these eyes may not be normalized. So is their, equator or a capsular size. So the normal lens may not be suitable in such cases. With this background, I'll get started with the cataract surgery in a pediatric age group, particularly when we have an anterior segment developmental abnormality. Do not have any relevant financial disclosure. I'll start with about 5 case scenarios. And this was a 12-year-old child, who had a severe glare and a blurring of vision, particularly during the DNI. This was about 5 to 6 years. And vision was 20/80. We could not, refract and give any spectacle. I'll come to that, why we could not refract him. On a slit lamp evaluation, you have a medusa head-like appearance, growth in both pupillary axis. We know it is a persistent pupillary membrane. This is rather hypoplastic. If you look at, the visual axis, pupillary axis is completely obscured. This is on a dilatation. You could still see the central visual axis is obscured. At this point in time, I was not sure, does it have only hypoplastic pupillary membrane or even anterior polar, or, the lens is involved. And undilated, that's one of the reasons we had a challenge. We could not refract this particular child. And this is on a retro illumination. This is almost reminiscent of a classic posterior capsular opacification, okay? A dense hypoplastic membrane which is obscuring the visual axis. That explains the glare child has. So again, it shows undilated, dilated, and a close look on hypoplastic pupillary membrane bang on the visual axis. We do not know it is an anterior lens capsule or a separate pupillary membrane. Therefore, I did a UBM and a OCT. UBM distinctively showed this is a additional thick hypoplastic membrane separate from that of a lens, although it is inserted onto the anterior lens capsule. Sometimes if you look at in a similar spectrum, we would call all this now labeled under anterior segment PHPV. And this free-floating membrane sometimes can attach to back part of the cornea, as in this particular slide. The OCT confirms same. And I have excised one such a membrane, peeled off from the cornea, one membrane from the, you could see the post-operatively, the lens is intact. And there are sometimes iris membranes. You may not have a pupillary membranes. And when we look at, gonio is so important in these cases, these membranes can extend up to the angle structure. Since, they have a smooth muscles, they have a higher propensity to develop secondary angle closure glaucoma. It's very, very important to rule out any glaucoma association in these cases. So I'll take you through a brief surgical video. There's the left-hand side is the first surgical video on the right eye. So inflating the chamber, carefully severing the communications between the colorative iris and the pupillary membrane. This is what we typically call medusa head, with the central dense hypoplastic pupillary membrane, which is in fact, anchored to the anterior lens capsule. I did exactly like what we do here, Rexis, peeling up very carefully. And I was little concerned. Hope I have not removed anterior lens capsule. I'm obsessively, checking thoroughly. It's not an anterior capsule. You can see a ring, an intact anterior lens capsule. This is a lens preserving excision of the pupillary membrane. And exactly we did the same steps in the other eye as well. You could see again, I'm peeling off membranes. Care is taken not to damage lens, iris in the process. And again, examining the very thoroughly. So anterior capsule, in fact, indeed, intact. You can see the ring, a pigmentary ring. That is the site where pupillary membranes were, stuck to. And histopath did confirm me there is no anterior lens capsule. Post-operatively OCT, UBM showed intact lens capsule. This child recovered, completely 20/20 vision with 8 diopters of hyperopia. As a rule, PHPV always have microcornea, microophthalmos. We have to be watchful for that. Same we published. And not all pupillary membranes need a surgical excision, only if they are symptomatic. It's very important to use meticulously, newer diagnostic modalities to plan your surgery so that, lens can be preserved in these cases. Even though we had a good outcome, but it is important to closely monitor these cases for any refractive surprises, a cataract or a glaucoma development in the future. We'll move on to the case 2. This was a 7-year-old female child, again had a white opacity since birth, had a suboptimal vision. At the time of presentation, child had only, the finger counting close to the face in both eyes. Slit lamp examination right eye showed a central calcification, and we could on a slit wave would see lens fail to separate from the cornea. The slit images were directly taken under microscope. This keratoiridolenticular dysgenesis, and left eye is much more severe than the right eye. And the B scan did not show any posterior segment involvement. UBM, they are not running. And what I did is conventionally we used keratoplasty with a lensectomy. They independently report outcome. To overcome that, what I did is, if you have observed the surgery, I went inside the bag and did an endocapsular lens aspiration along with the bag removal, and also a little bit about sphincterotomy. Left eye was a little severe, and the right eye could again see I'm going inside, directly inside the bag. The idea is that, you can see a subluxation. This is a subluxation part. We didn't want to spill any lens material into the vitreous cavity. That would lead to, smoldering, prolonged inflammation. And once you, evacuate entire lens matter within the bag, then inflating the chamber. Since, the right eye is a milder variant, when I'm trying to preserve the bag and capsular ring, using the pediatric rhexis forceps to design my capsular rhexis. And there is a stump, which is attached to the back part of the cornea. So here, if you can see, I'm carefully dissecting out. So normally we have a, temptation to, sever that communication between the cornea and lens. That should never be attempted. The reason is it can lead to a Descemet detachment. You could see a tiny opacity, the pedicle, that's where, the lens was, anchored to the back part of the cornea. Postoperatively, the right eye was a less severe eye, had a clear visual axis, unlike a left eye, which has a severe case, developed a glaucoma as well. So even these cases with the type 2 Pieris anomaly, where you have a keratoiridolenticular dysgenesis, can be managed by in type 2 endocectomy in these cases. Key message is avoid keratoplasty in these cases. So they generally do not do after a keratoplasty. In the interest of the time, I'll stop after this particular case. This was a 3-month-old child, again seen in a glaucoma clinic. And the child had a bilateral cataract. If you look at, this is the right eye, which has a severe dense, almost reminiscent of a developmental cataract with a numerous iris strands. So this is a little more than a developmental cataract. If you look at carefully left eye, there was a posterior excavation. So indeed, we are dealing with the bilateral PHPV, although this is less than 20% of the cases you would see a bilateral. The B scan and UBM did actually show this is a PHPV. And a similar case, representative case, such as because of this tractional pull by the PHPV card, you can actually see a large lens coloboma. That's basically lens, dehiscence there. So we need to avoid hydro procedures because eyelid may be intact in these cases, and one has to completely remove the lens before even touching the PC. And the second case where there can be second commonest cause of acquired cataract. because you have a lenticonus like an eye drops, it can rupture anytime, and overnight the family member parents can actually realize child has a total cataract. So you have a the fibrous ring. So if it is present on the posterior capsule, we call it as a Daljit Singh sign. You have a fishtail appearance, all that indicative of avoid hydrodissections, lens mobility, keep your phaco machine settings as low as possible, so that to prevent lens matter spillage. Again, you have a stalk, we call it as a Salmon patch pink sign. You can see a blood vessels on that. So what we have to do is leave a frill around the PHPV so that it doesn't bleed. And it is also very important to do sometimes the Doppler UBM in these cases to know the flow dynamics of PHPV to minimize catastrophe like vitreous hemorrhage and other complications. So even in such a cases, we can safely put an intraocular lens if we can systematically plan these cases. So apart from a clinical evaluation, a good UBM study is a prerequisite before embarking on a cataract surgery in these cases. So since we had a good capsular support, did a IOL in a sulcus, then achieved an optic capture that will give an extremely good outcome even in such a challenging cases. Generally, PHPV is considered as an extremely poor indicator of a cataract surgery. Again, this is one of the case which mimicking like a type 2 Peters anomaly, but it was basically pseudo-Peters anomaly. It's again anterior segment PHPV.
Hello.
As a rule, the
Hello, Dr.
microcornea
Muralidhar.
microphthalmos is a rule here
Hello?
because of the secondary glaucoma.
Yeah, I think we are running out of time.
Yeah, 60 seconds. So this is anterior segment PHPV. We could see the iris strands and subluxation. Again,
Here it is not coming, no.
attachment from the back part of the cornea. You have a central opacification that cleared subsequently. Again, did a good vitrectomy and left a small frill around the PHPV stalk, which I'll show you post-operatively. This corneal opacity cleared post-operatively. You could see the stalk and retina attached, and this child had a 2200 best contact lens vision. So to conclude, surgeon should be aware of a diverse spectrum of anterior segment abnormality, and these associated with higher likelihood of post-operative adverse event, particularly secondary glaucoma, can have a corneal decompensation if we are not carefully planning, and might need a reintervention in the form of membranectomy, glaucoma surgery, and so on. And these children's may
Hello, Dr. Muralidhar.
Yes.
Yeah, actually we are running out of time.
Yes, sir. Yeah.
Sorry to interrupt you.
That. So I think now I'll ask our second speaker, Dr. Murli Asuri, to.
Yes, Krishnamacharya.
So before Dr. Murli Asuri comes, if there are any particular questions, I'll be very happy
At
to answer.
the end, we will take up, sir.
Yes, sir. Thank you.
Yeah. Thank you so much.
Thank you, Dr. Muralidhar. And now we call upon Dr. Murali Krishnamacharya Asuri. We heard about cataract surgery in anterior segment problematic situations. Now we go on to the routine one, the nuances of doing a pediatric cataract surgery as a primary procedure by Murali. He was earlier at LV Prasad and now he's on his own in a practice setup and has a vast experience in dealing with these situations. So let's have him speak. Murali.
Good afternoon, everyone. For those of you who plan to perform pediatric cataract surgery and those who are already doing that, it's important to understand the subtle differences between an adult and pediatric cataract surgery. That's what we are trying to highlight in this particular talk. And some of the views expressed here are personal and anecdotal, so I will point out to those whenever we reach those slides. Before you actually start the procedure, it's very important to make two things sure. One is the depth of anesthesia. The child has to be adequately anesthetized so that the eyeball doesn't roll up or roll down. It should look straight up. And secondly, you have to instruct the anesthetist to make sure that the extraocular muscles are relaxed so that there is no compression on the globe, which in turn could lead to positive pressure of the vitreous. The second important thing is, before you start the procedure, you need to make sure that the patient's head is properly aligned so that the eye looks straight up towards the microscope. You can't make adjustments midway during the surgery because the child is under anesthesia. For me, the most important thing to ascertain is the pupil dilation. And in case if your pupil is not adequately dilated, I would always recommend that as a first step, when you made the stab incision with the MVR knife, inject your balanced salt solution, which is already mixed with adrenaline, which is the common practice in all our procedures. Just a moment, the videos. So herein you can see that before we have done anything, we have injected the balanced salt solution, and you can see the pupil dilatation, which is going to make life easy. With respect to capsulorhexis, always aim for a small rhexis, because a small rhexis can be enlarged, not vice versa, and it has to be well centered. Make sure that you have a deep chamber with a good retentive viscoelastic. A microrhexis forceps is very important to have in your kit, and just make sure that you always pull the capsule towards the center, not centrifugally, and always grab it close to the point of tear. So this is just to highlight how you would perform a capsulorhexis. Can we switch off these lights, please? You have made the after you made the initial puncture, you would raise a small flap of the capsule, and thereafter always use a Utrata forceps or whatever capsulorhexis forceps that you're comfortable with. I would not recommend you to proceed with a cystitome for capsulorhexis in children, because it's very difficult to control the highly elastic anterior capsule. For some reason, I think I'm not able to advance the video for some reason here. So essentially hold the capsule close to the point of the tear and always keep pulling it towards the center, so there is no runaway of the rhexis towards the periphery. We're all the time pulling it towards the center, not letting it run away. Keep holding it again and again. Don't just do it in a single continuous manner. Keep watching the advancing edge of the tear to make sure that it doesn't go towards the periphery. You can see, keep pulling it multiple times, holding, reholding. So that's a kind of a capsulorhexis you want, the size-wise about 5.5 millimeters or 5 millimeters and well-centered. And wherever there is opaque lens, total cataract, you always would use a trypan blue under an air bubble and proceed with your capsulorhexis as you would do in an adult. But of course, the same principles stay, holding the capsule close to the point of tear and pulling it centrally. You could always enlarge the rhexis. If you have started with a small rhexis, you could always go back and enlarge the rhexis. Here is a small rhexis which we plan to enlarge after evacuating the lenticular contents. The bag has become now flat. There is no longer the lenticular pressure from inside, so it's going to be much more easier when you plan to enlarge this kind of a rhexis. So gently pull this rhexis. This time you could pull it gradually and more centrifugally so that it does not immediately join the main rhexis. You want to take it 360 degrees all around this cut. And keep pulling again and again multiple times. You have to regrasp the rhexis, but this time you are not pulling it towards the center. It is mostly the way you would perform your adult capsulorhexis. The important thing is to approach this rhexis from different directions. You just cannot use one port for enlargement of your rhexis. You have to use your main incision, you have to use your side ports as well. And this is where I think having your microrhexis forceps would be very beneficial, because you can, like as you can see here, you are able to enter from the side port with your microrhexis forceps, and you are able to grasp the rhexis and pull it towards circumferentially. Lens aspiration is done as you would do with the routine cases. Initially, a good hydro would help, and you could use a coaxial or a bimanual aspiration system. For children who are below the age of 5 years, where we routinely perform a primary posterior capsulotomy and anti-vitrectomy, you would want to have the side ports as well, so a bimanual aspiration would be useful. Whereas in adult cases, slightly older children, we can go ahead with the coaxial type. This is something that you would see in children who are less than 1 year of age, infants, where we have implanted lenses. We started seeing this membrane formation, which is a membrane which is on the anterior surface of the lens. This is a couple of weeks after the surgery or within a month. What we realized is in these children who are very young, our experience was limited at that point of time. Subsequently, what we realized was we have been not performing this particular step previously, and adapting this step helped us. After performing the lens extraction, we go inside and remove the lens epithelial cells from the undersurface of the capsulorhexis for at least 2 millimeters all around. So the grayish material that you're seeing is all the lens epithelial cells which is being aspirated. And once this material is aspirated, when you implant the lens, we stopped seeing the postoperative fibrotic changes. Coming to the primary posterior capsulotomy, usually we would do that in children below the age of 5, or wherever we think a child would be uncooperative for a YAC capsulotomy. Subsequently, we would do a primary posterior capsulotomy in even older children, or where there is an nystagmus and you think you cannot be performing a YAC capsulotomy comfortably, you would do the primary posterior capsulotomy with anterior vitrectomy. And the vitrectomy is always performed from the side ports, never use the main incision. For those of you who are conversant with the pars plana, you can choose the site depending on the age of the child. And the vitrectomy has to be limited, wherein you would just remove the vitreous that has come out of the primary posterior capsulotomy and also what is lying in that area. You should not be performing an exhaustive vitrectomy in these cases. IOL implantation is as you would do in an adult. Just make sure that the lens goes into the bag. If there is a primary posterior capsulotomy, make sure that the leading haptic does not go behind the posterior capsule. Make sure that it goes into the capsular bag. So this is just to show after you have implanted the lens, you make sure that the rhexis is behind the lens. So that kind of confirms that you are in the right place. We almost always use hydrophobic acrylic IOLs. We don't recommend using hydrophilic lenses. And always it's a good idea to close the wound with sutures, because in children, even though on the table you may find the wound to be secure, post-operative leaks would be meaning a repeat anesthesia. And don't forget to bury the knots. The last thing is not to meddle with the iris. Post-operative inflammations are almost always because you have meddled with the iris. And for this reason, we have stopped doing a routine peripheral iridectomy in all the children. And we strongly recommend use of mydriatic cycloplegics. So finally, the key points are: make sure that the child is properly positioned, the anesthesia is adequate, the pupil dilation has to be the first thing, and make sure you use the BSS mixed with adrenaline before you start the procedure. A small rhexis is to begin with, and you can always expand it. Vacuum polishing the epithelial cells, particularly for infants where you're planting IOL, and do not meddle with the iris. Use a hydrophobic lens. And after you have done the placement of the lens, the residual viscoelastic should ideally be cleaned with a Simcoe cannula in case if there is a primary posterior capsulotomy, so that you don't hydrate the vitreous and bring it forward. Thank you.
Thank you, sir. Beautiful talk.
Thank you, Dr. Murli. Having seen his videos and having heard the practical tips and points that he has told, I'm sure those who haven't been initiated into it will also take heart and start doing pediatric cataract with some confidence. The surgery is going to take a while for you to master, but somewhere you will have to begin, and that's where these steps and practical points and videos come into play their role. From the speakers here, we have now Dr. Somashila and Dr. Akash Balanje at present. Some of the others are either on the way or in other halls. So I would request Dr. Akash, who is a vitreoretina consultant at L.V. Prasad Institute, Hyderabad, to present his topic and educate the juniors and us combined alike. We would give him those 8 minutes, and that's it. All yours.
A very good afternoon to one and all. So I'll be speaking a little bit on persistent fetal vasculature. I'm a vitreoretina consultant at L.V. Prasad Eye Institute. I do not have any financial disclosure. So persistent fetal vasculature, as you know, the hyaloid artery is the one which nourishes your lens during your intrauterine life. So it kind of nourishes your anterior segment, and hyaloid artery gets its branching from the ophthalmic artery. So this hyaloid artery is expected to regress at around 6 to 7 months of intrauterine life. And the regression of this hyaloid artery mainly happens because of the apoptosis or even the astrocytes. Those are the macrophages that are present inside your eye, which helps in the regression of this hyaloid artery. But if the hyaloid artery persists even after the child is born, then we must suspect, or the condition is known as persistent fetal vasculature. Previously, the terminology was used as PHPV, persistent hypoplastic primary vitreous. Now the latest terminology is persistent fetal vasculature. So you can see a beautiful ultra wide field image here, which you can see the stalk which is having a connection right from the disc up till your crystalline lens. So if the fetal vasculature does not regress, then what happens is that the light, you will see the lens opacification. So the light entry inside the eye will not be good. So we can expect varying degrees of cataract or varying degrees of opacification. And the parents during the child in its infancy, the parents might come with the complaint to the clinician saying that we have observed whitish reflex during photographs, or child is having a whitish reflex or white color eye. So one important thing that we must remember is majority of the cases of persistent fetal vasculature is unilateral. So it is unilateral and it is sporadic. That is, it does not have any genetic predisposition. So when such a condition is there, when you see this in infancy, we should remember certain differential diagnosis. So some of the differential diagnosis you need to remember for unilateral leukocoria is persistent fetal vasculature, Coats retinopathy, and retinoblastoma. Whereas bilateral leukocoria, if you see it in a child or infant, then you must ask the parents a history of retinopathy of prematurity, where invariably there will be history of preterm delivery, or familial exudative vitreoretinopathy, incontinentia pigmenti, or Nuri's disease. So all these familial conditions and ROP, these are the conditions where you have bilateral leukocoria, whereas in persistent fetal vasculature, majority of the time it's unilateral and it is sporadic in nature. So here you can see there is a ultrasonography which shows there is a connection from the optic disc right up to the crystalline lens. So due to the persistence of this fetal vasculature, the eyeball size will be, this fetal vasculature does not allow the eyeball to grow in size. So most of the time you will encounter microphthalmia, and there will be hypermetropia, and the axial length will be much lesser than the other eye. And that eye will be severely amblyopic. So there are a lot of challenges. So, and if that all, this persistent fetal vasculature can be present as a separate entity, or it can also be present in macular condition as in conjunction with the other entities. So let me quickly run through. So what I mean to say is they can present inside in certain condition, like in ROP also, they can be present, and the eye in which the persistent fetal vasculature is present, they will have much more severe presentation. You can see severe retinal folding in one eye compared to the other eye. Here you can see a familial vitreoretinopathy, whereas the lower images you can see the retinal folding is much more severe. This is because the fetal vasculature is present and it has caused much more folding of that retina. So let me just show you a surgical video here. So usually this fetal vasculature will be present, and which will throw the retina into multiple folds, retinal folds. So you must be very careful in dissecting these fetal vasculature from your retinal fold to prevent iatrogenic breaks. So one of the indication here is the recurrent vitreous hemorrhage that has happened in this child, and you can see there is a persistent fetal vasculature in one of the eye, which has caused a severe retinal folding that is seen here, and the surgeon must be very careful in dissecting this fold from the underlying retina and must not cause any iatrogenic breaks. So another important thing is not just posterior segment, it can also present with the anterior segment problems also. So yeah, so if only posterior segment problems are present, then usually it will be limited to the retina and retinal folding. But if it is present with an anterior segment problem, the video is not So what we need to remember here is, if at all there is anterior segment findings, then you will see anterior segment shallowing of AC can be seen, and you can also see elongated ciliary processes, and the other important thing is there can be corneal haze that is seen. Yeah, it is playing now. So this is a condition, as in the previous video I showed the posterior segment manifestation. In anterior segment manifestation, you can see there is already clouding of cornea, and there is posterior synechiae that is formed, and there is also shallowing of AC. So you must gently remove that synechiae and create a plane, and you must be very careful while placing your cannula. The cannula has to be placed much more horizontal in these cases where there is anterior segment problem, because the retrolental membrane and the PHPV is right behind your lens, and invariably you can cause a damage while inserting the cannula. So make sure you're placing your cannula much more horizontal. So you can see there is clouding of cornea, peripheral anterior synechiae, shallowing of AC, and there is angle closure glaucoma also in these cases. So along with posterior segment, if anterior segment problem is seen, then there is the presentation will be much more severe. So you can see here the Burgess space, where you can see there is a retrolental membrane with the pooling of blood in that Burgess space, and you can see the elongated ciliary processes on either side of this PHPV. So the cannula was placed horizontal, and with the visco, the entire synechiae was removed, and the surgeon is gently kind of dissecting this PHPV stalk. And we must be very careful, because these are very highly vascularized stalk and can cause tremendous bleeding on table. So you must be ready with the cauterization instrument. So if at all intraoperative bleeding happens, then you should cauterize there and then. So some of the take-home messages, just to summarize, as a general ophthalmologist, the one thing that we must remember is PHPV is unilateral, it is sporadic. So some of the DDs for unilateral leukocoria in infants will be your PHPV, retinoblastoma, Coats retinopathy, and it usually causes microphthalmia, hypermetropia, and the axial length will be much lesser, and one of the eye will have much more severe presentation. So with this, I would like to end my talk, and any questions, I'll be more than happy to take.
Well, it's not an LV Prasad branch, but it's not an LV Prasad branch, but it's a new center which is called Shantilal Shangvi Eye Institute, and I'm happy to be representing both centers now, LV Prasad and SSEI. And thank you very much, ma'am. Yes, yes. And it's a pleasure seeing you, and may I say that you're growing younger and younger every day, every time I see you. How many are PGs here? students or young enough like PGs at heart? All right, so I thought I'll present cases because it gets very boring and the videos always get stuck. So I'm feeling very happy I didn't present any videos. So my first case, she's a 7-year-old girl presenting with uveitis. The parents got her because she was now stumbling and falling down. She had cataract in the right eye, which the parents noted. No other history as per the family. The right eye vision was only 2400, about 20, less than 1/60 or less than 6/60. The left eye, she just had light perception. Pressure was okay in the right eye, very low in the left eye, and she had a membranous cataract. Am I done? I don't mind. So, so now for this patient, because you can't see anything, right? You can have a B scan, of course, but that showed some echoes in the vitreous cavity. So the UBM. What the UBM shows is that this is a cornea, this is the iris. So there's a forward bowing of the iris, so iris Bombay, which is literally closing the angles. And there is an intumescent cataract in there behind this anterior surface of the lens. And you can notice the ciliary body. In the left eye, you can see it's looking very distorted. So the ciliary processes were just not there. They were very distorted, very atrophic. Whereas in the right eye, we still had preservation of the ciliary processes. So we decided to go ahead and start the child, because you can't just go and operate on oral and topical steroids, as well as we worked up the child for other investigations and then started the child on immunomodulators. Methotrexate is a drug of choice. And then the patient was sent to Akash maybe, or whoever was there, and they did the pars plana lensectomy with vitrectomy for this child, because it's a very advanced case of pediatric uveitis, most probably JIA. So that's a complete picture for this child. So the child is regular follow-up now, from 7 years of age, is now in her 20s, and is still on immunosuppressants. That's because this particular child, the disease doesn't seem to have regressed even in adulthood. Every time we take off the medication, the patient has the problem again. So the second case is 3-year-old presents with nystagmus and congestion. We already had lab tests done elsewhere, of which most of the tests were normal. So we went ahead and did examination under anesthesia. And what it showed is that we could see very early band-shaped keratopathy. I'm not sure if it's visible in the back, maybe it is. Again, the AC was very shallow. In fact, there was multiple posterior synechia 360 and pulling the iris, dragging the iris, so that you could even have some atrophic holes. So this is long-standing for this child, because the child doesn't know how to complain and would not have complained. The intraocular pressures were low, very low in both eyes, and even the axial length was reduced because of the hypotony in both the eyes. So what is the plan? Again, oral steroids is inevitable, though we don't like to give in such a small child, but we can't start biologicals, for example, so there's nothing else that works. And our plan was only as bridge therapy, start oral steroids, and go on immediately to immunomodulators almost nearly simultaneously, after ruling out all the conventional infectious causes that can happen. So this child, we tried methotrexate as once-weekly infusions, but we still couldn't control the disease, so we started the child on mycophenolate mofetil, 500 milligrams once a day, and then we had to increase. Even then, that was not enough to control the disease, so then ultimately we added cyclosporin, and the child, then the inflammation was controlled. Underwent pars plana lensectomy after around 4 or 5 months of therapy, and no intraocular lens was placed, as in the previous child also that I mentioned, because you cannot place intraocular lenses in such small eyes badly inflamed. It just won't do. And the patient continues to undergo, she's very active in the active phase, continues to undergo repeated EUAs. So what is the flavor of the topic today? That's cataract and pediatric uveitis. It's close to 25 to 70% of these patients develop cataract at some time or the other. They may either present with the cataract, or at some time or the other due to the course of the disease, or if nothing else, due to the therapy. Okay, so if nothing else, at least because of the steroids, the child may develop cataract. And then the incidence increases with the duration of disease. So some of the children may still have a good prognosis. So an older child, if a child presents to you in the teenage life, has a better prognosis as compared to very young children, as I showed you earlier, based on etiology, Fuchs heterochromic cyclitis, and just an idiopathic anterior uveitis, immune-mediated. These are fairly okay prognosis. You can expect a good outcome. The fair prognosis, children with fair prognosis for cataract surgery includes JIA, which is very well controlled. Immunosuppressants are going on from day one. And something like JIA, but the enthesitis variety, which is HLA-B27 positive, for these pediatric patients. So these two are well controlled, or just a one-time infection in the eye leading to inflammation, and then that infection is resolved. So this may have also a fairly good enough prognosis for these pediatric patients. But it's going to be very poor in terms of outcome if you have an extremely young one-year-old child, or other indications such as if you have bad uveitis, posterior uveitis, VK, sarcoidosis. So these are all associated with very poor prognosis. So based on, for all children, the parents, I do not paint a very bleak picture. I do tell them that otherwise they will not bring the child for follow-up. I do tell them that we have something, we have medication, and we have surgery, and we keep doing that, the child will get better. You have to give me 5 years of your life and your child's life for checkups and so on, and then we'll get on track. So this is what we tell the pediatric patients, the parents. So this is a case of sarcoidosis in a pediatric patient. So you can see the large granulomatous inflammation and the Kettic precipitates. And what about the JIA child? So there's a high morbidity vision-wise in the JIA associated uveitis. Cataract is very high, as I said, almost 84, I would say 100% actually, children get cataract in this group. And even glaucoma, unfortunately, is very high, about 30%. Band-shaped keratopathy in almost 2/3 to 3/4 of these children. And you are looking at long-term medical therapy for these pediatric patients. So what is the stepwise approach before you take up the patient for cataract surgery? It's extremely important that you time the surgery well. You need, though it says 3 months, I would say that even more than 3 months if you can. There's a dilemma over here because on the one hand, the child is in the amblyoptic age group. On the other hand, you can't operate if the eye is inflamed. So you have to find a balance, a midway between the two, inflammation control as well as the age group, and that the multiple difficulties in trying to achieve that. So just before surgery, you can give a short pulse, either oral, topical, at least topical, and then at the end of surgery, you can give a sort of a posterior subtenon injection. Don't give intravitreal injections, though we can give Ozurdex a little bit safely, but intravitreal injections have a higher chances of glaucoma in these patients, so I usually tend to avoid that. If there's band-shaped keratopathy, you need to do removal of that, which is simply done with EDTA chelation. So pars plana lensectomy with limited vitrectomy for patients under 12 years of age. In older children, if you have extensive anterior and posterior synechiae, you'd still have to resort to this technique. And in children, doesn't matter what age, but if there's extensive iris manipulation, you might not want to put the intraocular lens right away. And in a young child, just avoid putting the intraocular lens. It'll contract the entire bag, it'll start pulling the ciliary processes, and then you'll end up in hypotony. So other procedures, as I said, EDTA chelation. Sometimes if you're also a LASIK surgeon like I am, so you can do two-step procedure, do the cataract surgery, and later you can remove the calcium with PTK, for example, for these children, and plenty of periocular regional steroids in these children to control the inflammation. And I told you about the controversies regarding the implantation. To make it very simple, don't put in a patient who's less than 12-ish years of age. You can put it in an older child if there aren't any posterior synechiae and so on. But you watch the inflammation first. You can go ahead and put it later as well. But you don't want to have this kind of problem where the eye is literally spitting out the lens. So the lens was placed in the bag, but has now come entirely ahead of the pupil and is bound down over there. It's also meanwhile caused cyclitic membranes. It's dragging the ciliary processes, and the eye is going into hypotony and shutdown. So you have to remove everything, remove that, remove the adhesions, and put siliconol in the eye. So that's a very chronic stage. So to summarize, increased steroids, you must have a much closer follow-up, and as much as you can control inflammation with immunomodulators for sure. And cystoid macular edema is something we all know. You have to monitor for that. And you can give periocular posterior subtenon steroid injection for CME, works pretty well. My choice is to use methotrexate in most of these pediatric patients right away, upfront. I'm talking about immune-mediated disease. And second choice is MMF, second choice because of the expense of that drug. And also, thanks to, we have a very friendly rheumatologist, Dr. Rajkiran, who's all over here. So in case you want to consult him for your patients, he will be here. And he has been so helpful in helping us with our pediatric patients as so adult patients also, that we are very confident now of starting biology. Well, we don't start, we make him start the biological agents as well for these patients, wherever we don't achieve control with MTX or with MMF, and then he helps us and we resort to using these agents, and somehow or the other we get the inflammation under control. So we handhold the parents. As you know, all of you who are practicing pediatrics, that is not just the child, but it's 3 people or even 10 people in the family. That in India it's at least 5 people that you need to address when it's a pediatric patient, and it needs a lot of counseling. So the goal is, immunomodulators plus counseling equals a good outcome. Thank you very much.
Yeah, thank you all audience. And I think probably it is the best time to start the VVA session. So those who are the VVA session convener and then the speakers, panelists, everybody must be ready. Thank you faculty and the audience.
See, when you have a session in this inaccessible bottom corners of convention where
Sir. Yeah.
When you express 20 by 40, 20 by 500, how to convert it?
Sir, there are standard charts are available, sir.
But
Logma charts.
But what we record here is every Snellen chart.
No, actually the charts are available, sir, nowadays. Logmar's values, equivalent values on Snellen's and then Logmar and then in decimal notations. Nowadays they are available, sir. Readily you can refer to that. Yeah.
Yes. It's for, yes. I thank Dr. Vidyavati and Dr. Raman. No, no, our speakers are there. I thank the previous session for handing over the stage on time. So we'll begin the uveitis session. So this is uveitis for everyone. We have some very prominent uveitis specialists from Hyderabad. Dr. Soumya Basu, Dr. Somshila Murthy. Most of them don't need any introduction. Dr. Malika Goyal and myself, and of course Dr. Raj Kiran. Dr. Raj Kiran is an eminent rheumatologist. He has his own practice. And I welcome all of you to the uveitis session. And I think Dr. Soumya Basu is on his way. So we'll start the session with Dr. Somshila Murthy. She'll be talking about 5 pearls, diagnostic pearls in anterior uveitis. How many of you fell asleep during my earlier presentation? If I play the same thing again, how many will realize it's the same thing? Yeah, press it. Okay, it's not the same thing. So, good evening everyone. I hope you are all awake. You can only take a dose of uveitis and a big dose of uveitis if you're completely awake. So I thought that in order for you to be woke, we'll take you through some cases of anterior uveitis. And since this is Hyderabad, the city of pearls, so I thought we should give you some clinical pearls, okay, which are free. What's that, sir? Anyway, so I thought we'll go through some common scenarios and what is the commonest anterior uveitis entity. So this is very good for you in practice and also for exams perhaps. So the commonest uveitis entity is about 50% of the time you're going to see this if you're sitting in the uvea clinic and only anterior uveitis is what you see. The second is that around 11 to 15% cases fall in this entity, which we often miss or perhaps we misdiagnose. Around 10% are underdiagnosed. And why it's underdiagnosed? Because it's another common entity. So once you see my description, then you will recall if you're not seen them already. Then pediatric uveitis, we just talked about it, so probably I'll just skip it. And the last part is very low, less than 2%. So whenever they don't fall into any of these categories, you can think of masquerades, such as maybe it's an infectious cause, like for example, a foreign body that has fallen into the eye when there's history of trauma, or maybe there are some tumors. So these are very, very rare actually. So, or maybe even parasitic infestation. So they're very specific entities and very rare. So we'll be focusing mostly on the first 3 scenarios actually, because the 4th scenario I just completed. So the case number 1, and PGs can pay attention. If I come as your examiner, you've had it. Luckily for you, I won't come. So the 28-year-old male presented with sudden onset of quite significant symptoms. He had redness and everything. His vision had dropped. It was 624. He had 3+ CCC. He had fine keratic precipitates, which you cannot see in this picture. And there was at least 3+ reaction in terms of cells in flare, 4+ cells actually. And he had a trace hypopyon. Can you see that in the back? Students, girls, boys? Hopefully you can. And the lens itself was showing some kind of whitish membrane and the pupil was not dilating. So any takers on what this could be? Young male patient presents with sudden onset symptoms mainly anti-uveitis with a hypopyon. Somebody said it already. Please say loudly. Exactly, yeah. You heard my presentation before. Who is that? Cheating. So this was a patient who, when you ask more history, says that he was already diagnosed as HLA-B27 4 years ago, and he had similar episodes in the right eye for the past 2 years. He was on treatment with HCQS, not by Dr. Rajkiran, but that was all that he was receiving, which he had stopped because his disease was pretty much okay systemically, so the rheumatologist had discontinued the HCQS. Interestingly, just his most recent episode was quite severe, came just a month after stopping the medications. So we have Dr. Rajkiran, we can ask him that does it affect it like that. And so we diagnosed as non-granulomatous anti-uveitis. That's both the pathological diagnosis, non-granulomatous, the anatomical anti-uveitis, and even the etiological, so HLA-B27 type of disease. What do? We start on intensive, potent topical corticosteroids. I always use atropine for these patients, and I gave a bedtime steroid ointment also. And the patient was asked to follow up after 48 hours because there was also a streak hypopyon. Not that I suspected my diagnosis, but mainly so that I could step down the frequency of topical steroids and then, see if the patient is getting better or not. So it got better, and within two or 3 days, his pupil began dilating nicely. What you can see here is that all those iris pigments, which if we had not started him on treatment, might have become posterior synechia. So this patient had a good outcome in that way, and we kept on stepping down his steroids over the next 1 month and continued for about maybe 6 weeks to 8 weeks. And we again pushed him back to the rheumatologist to see if that they could again start therapy, because then this patient had a cycle where he kept coming back with inflammation. So we had to start him on immunomodulators once again for his eye disease this time, though systemically he looked to be okay. So HLA-B27 is a common entity. Some of my colleagues always say that get PCR testing. So if you strongly suspect HLA-B27 based on the ocular disease, but the HLA-B27 is negative, so you can ask for a repeat test, but ask for the PCR technique. And it's easy to treat, as you saw. It needs topical steroids. Only in about 10% cases, when there is a lot of vitritis or very severe, you may use oral steroids. And you don't need to use it for weeks or months together. You can use a short course of oral steroids if it's only ocular involvement. And then for those patients, a small minority of them, where as soon as you stop the topical steroids, you taper and stop, then within no time at all, they come back with inflammation. So when you have patients who have more than 3 episodes a year like that, then it makes more sense to start them on oral medication to keep this disease under control, rather than go on putting steroids in the eye, which, as you know, can cause cataract and glaucoma. The problem with this disease is that you can have patients underdiagnosed, undiagnosed. So here's an elderly man with one of my patients with ankylosing spondylitis. This is another patient with Dr. Kalpana Babamurthy and Dr. JB they've described. So all this time that they've been going around, they've not been diagnosed with this simple test, which is HLA-B27. Although they are literally, the diagnosis is walking and talking along with them. So that has ankylosing spondylitis and spondyloarthropathies associated